Good morning, everyone. It's Wednesday morning in the House Healthcare Committee. This morning, we are starting with Devin Green, who is with the Vermont Association. I always get this wrong. Sorry.
Of hospitals and health systems.
Hospitals and health systems. I always want to switch them. Anyway, so welcome. I think because we have so many new committee members and you have not been before us yet, we'll start with some introductions. So Joe, we'll start with you.
My name is Joe Andriano. I represent the Aston Rutland District. That's Orwell, Shoreham, Whiting, Sudbury, and Hubbardton.
Great.
Alan DeMar, representing Enosburg and Montgomery. Nice to meet you.
Hey, Devin. Alyssa Black, Northern Essex.
Roy Houghton, City of Essex Junction.
Jonathan Vaughn, I'm from Barrytown, represent Barrytown and East of Williamstown.
Rick Portis, Lincoln, Bristol, Moncton, and Starksboro.
Daisy Rebecca, Winooski.
Hi, Devin. Leslie Goldman, Bells Falls area, Wyndham 3.
Howard Peterson, Clarendon, Wallingford, West Rutland, and Rutland Town.
And we do have someone zooming in with us. I'm not sure if he is listening
I'm
right
here.
now. Okay, great. If you want to introduce yourself, great.
This is Bobby Farley's Rubio from Caledonia 1, representing Barnet, Reigate, and Waterford.
Great.
Great. Wonderful. We'll turn it over to you.
Great. So I'll start by introducing myself. I'm Devin Green. I'm Vice President of Government Relations at the Vermont Association of Hospitals and Health Systems. And I've been there for about 6 years. Prior to that, I worked under the Shumlin administration on single payer and on implementing the Affordable Care Act, the Special Counsel for Healthcare Reform. And prior to that, I worked doing elder law work at Vermont Legal Aid as an attorney. So that is all just to say I have no medical training. I can connect you to folks who do have medical training, but I am trained as a lawyer. So what does VAS do? We do a lot of things. A lot of our work is really about being a convener and a connector. We connect hospitals to policymakers. We have a lot of touch points with our hospitals. So we call them affinity groups. We have regular meetings, usually monthly or biweekly. And so we meet with CEOs, chief medical officers, chief nursing officers, ED medical directors, inpatient psych directors, HR directors, IT directors, compliance officers, and chief financial officers. So what that does is it gives us an ability to let everyone know what you all are doing. So we are able to say, here's what's going on with the legislature, here's what has passed, here's what you need to do now. But it also gives us information about what's happening within our hospitals too. So we can bring that information to you. It also gives us the ability to really coordinate between hospitals too. With these regular meetings, our hospital leaders have developed a lot of good relationships. We've been able to do programs like smart medical clearance in mental health, where for someone to get a mental health inpatient placement, they need to be medically cleared by an emergency department usually. And there's been friction in the past between the psych units and the ED units. And we've created a standardized system to help make that a little bit smoother and take away some of the wait times. So we do a lot of work between our hospitals and between departments as well. So now I'm going to step back and talk about Vermont. I know all of you know this, but we are according to the 2020 census, the most rural state in the nation. That means we have the most percentage of people living in rural areas. So places like Wyoming, they are big, they have a lot of land, but they are condensed in their cities in terms of their population. Vermont, Maine, those sorts of places, they have more population living in rural areas than those other places that we typically think of as more rural. It's also one of the oldest states in the nation, with aging individuals dispersed throughout the state. So I thought this map was really interesting just in terms of showing you county by county the various ages. So the dark blue is older and the lighter color is younger. And if I had a little more technological know-how, I would have like faded into this map that overlays the census map before, but keep it in your mind. These are where your hospitals are located. They are dispersed pretty evenly throughout the state. We represent 16 hospitals. Of those, we have 8 critical access hospitals, and those are smaller hospitals that are serving rural communities. So they have special federal requirements, and they get paid in a different way than other hospitals. We have one academic medical center, that's UVMMC. That's also our sort of tertiary care center that takes all of the really critical cases along with Dartmouth. And then we have 7 inpatient psychiatric care. So we don't represent the state hospital, PCH, but otherwise we have psychiatric inpatient throughout the state in a variety of different hospitals. And we also represent the VA. Go ahead.
What is a designated hospital on that legend there?
That is the psychiatric
Great, thank you.
inpatient. Yeah, so it's designated by the state to take individuals who are in state custody.
So I have a couple of questions, if you don't mind.
Sure.
Just clarifying. So when you said critical access hospitals get paid differently, can you explain that a little bit more?
Oh, yeah, I know. I was wondering if I should have said that. So they get paid a little bit differently than community hospital, like academic medical centers get paid a little bit differently too, graduate medical education money. Critical access hospitals, typically to explain it in the most simplest terms, you take the costs and for Medicare, and the federal government will reimburse you for costs. That used to be 101% at cost. My understanding is that it is now below 100%. I think it's 99%. So it's an attempt to, I think the federal government realized that rural areas needed access to care. And so they said, we are willing to cover these costs. And we know that you will need a little bit more than the costs given the inefficiencies of rural care and needing a little bit of a margin.
So that's at the Medicare level is where the difference is.
Yes.
But Medicaid is Medicaid statewide, and then commercial insurance is.
Correct. Yes. This is a Medicare designation.
Okay. And then on the 7 inpatient psychiatric care.
Yes.
So those 7 are within hospitals or adjacent or separate?
All of the above.
Okay.
So we have, within our hospitals, we have UVMMC, CVMC, Rutland. Those are within hospitals.
Okay.
Springfield has the Wyndham Center, which is sort of just down the road. And then we have Brattleboro Retreat. And then we have a few beds in the VA serving VA patients too.
Great. Thank you.
So yesterday, when DMH was in, we sort of had a question about precedent for state dollars going to any of these other facilities where psychiatric care is given. Have all of these 7 inpatient psychiatric care, have state dollars gone in to develop and maintain those beds?
Yeah, I'd have to look back. I know recently Brattleboro Retreat received state dollars to open up some new beds. And then I believe after Irene and the state hospital going away, hospitals received funding to build up beds.
And I don't know if this is the right question for this time, but we actually had a question yesterday about what the relationship is with Brattleboro Retreat right now and the state. I mean,
We're going to have Brattleboro Retreat come in, so why don't we have them answer that question? Great. Any other questions before we go on?
Okay. And then just Vermont hospitals in context. So I think I think we talk about Vermont we don't have a big population. Why do we have so many hospitals? We are overbedded. But when you actually dive into the numbers, Vermont has fewer beds per capita than the national average. And if you look at DC, which again, comparable population, 700,000 people, much smaller area. They have twice the per capita rate. They have 4 beds per 1,000. We have 2 beds per 1,000. Despite the fact that we're running pretty lean and we're in this rural and aging environment, we consistently rank as one of the top 5 healthiest states. States approach hospitals in a variety of ways, right? So there is, I think one of the reasons why we are so dispersed pretty evenly throughout the state is Vermont has taken a very clear regulatory approach. So you can do a competitive approach or a regulatory approach. And Vermont is squarely in the regulatory piece. They've been very careful with their certificates of need, which is determining what should be built for hospitals and services. And Vermont's hospitals are highly regulated. I think one takeaway I'd want from this slide is just to realize that in addition to state regulations, we have a lot of federal regulations. So we really try to align with our federal regulations too. So if you have ideas or directions you want to go in, please feel free to contact me and we can check and see if there's a federal regulation about it already, and just make sure those things are aligned, because misalignment there sort of adds to the administrative burden and cost.
What would you say is, well, let's phrase it a different way. Are federal regulations more plentiful than state regulations? I don't know if that's the way to answer the question.
I think it depends on who you're asking. Like, our hospitals might say, oh, they're both too much. But the federal regulations, they really dive into the nitty gritty in terms of we want you to provide care this way in safe ways and doing this and that. And if you don't, we will take away your Medicare and your Medicaid funding. So those regulations are really crucial to hospitals.
That's what the Fed says?
Yes.
Yeah, okay. And what do we say? In general?
It depends on where the regulation sits. There's some at the Department of Health where they could take away our license. And so that would also be a problem. And then there's the Green Mountain Care Board, which can sort of set our budgets and work that way. That's less in terms of safety. It's more in terms of financial.
I just wanted to try to figure out if the feds regulate, why do we need to? I guess I didn't. It doesn't matter.
Yeah, I mean, I think, again, there's pros and cons to going the state regulatory route versus the competitive route. In the places where there's competition, there can be a big buildup of hospitals competing with each other and for-profit, and they're very much a sort of nonprofit by geography system at this point. So I've been, with all the discussion, I've been reflecting a little bit on healthcare reform. So we started in about 10 years ago on doing provider-led healthcare reform, moving from fee-for-service to value-based care. And the way we did that was we paid dues into One Care Vermont. Some of those dues were dispersed to community providers. I think going into this, hospitals were very much along the lines of, we are healthcare leaders, we can do this. And I think people were worried that efforts were going to be duplicated and hospitals might take over. And that was because hospitals had a lot of the resources at the time. I think now we have flipped that a little bit, and hospitals don't have resources, but we have a much greater sense of the importance of the providers outside of our four walls. So I think between the work in healthcare reform and COVID-19 and where we are now, we are doing a lot of interesting work around partnering with our community providers. And we know that we need to leverage every available resource because resources are just so scarce. So we have programs like in Brattleboro where we have the hospital partnering with a homeless organization and with the mental health agency down there to provide housing and mental health treatment and other care, and doing some really great things. There's a lot of hospitals participating in Veggie Van Gogh and addressing food insecurity as well. But as I mentioned, we are in a financial crisis, and I'm going to speak pretty frankly about it today. I think in the last couple of years, we were hoping it was COVID. We were hoping it was the after effects of COVID. We were hoping we could dig our way out of it. But at this point, statewide, we have a negative 1.9% operating margin. And within that, 9 out of our 14 hospitals have negative operating margins, including some of our larger hospitals. So it's not just the little guys that we're talking about anymore, those little critical access hospitals. It's bigger hospitals as well. Out of that, about 65%, so the majority of that are labor expenses. And then we also have a large chunk of expenses going towards medical and surgical supplies and pharmaceuticals.
Labor expenses, how much of that, are travel staff?
That's a great question.
You can get back to us.
I will get back to you on that. Yeah.
No question. Okay. All right.
Are people in the hospital, and this, Mario will jump on me and punch me when I answer. Because we have kind of competing things here.
Yeah.
You know, if we're all healthy, we're not using the hospital, okay? And I wonder, are people in the hospital busy, or is it not being used and not generating money? And is that the problem in hospitals? I didn't know.
We are going to get there. Let me save that for one of my next slides.
If people are sitting around twiddling their thumbs because no one's coming in, I'm sure that's not happening. That's why Mari told me.
No, that is
okay. No, that's
not where we're at. No, I mean, I think we are one of the healthiest states in the nation, despite all of the headwinds that we have against us, right? Like despite the fact that we have our elderly population and all these things going on, I think it's pretty incredible that we still have the good health that we do. One of the areas contributing to, and just sort of a peek into the way hospital finances work is through the cost shift. So if you look here, this is a slide from the Green Mountain Care Board from last year. And it shows how the columns on the left are government payers, and the column on the far right for each inpatient and outpatient part are commercial payers. And you can see here that a lot of the government payers don't cover the cost of care, and that is made up through raising commercial payer rates. So we are ending up in a system where commercial payers are having to pay for some of the cost differential left behind by Medicaid and Medicare, which is all to say that we have a great opportunity in Medicaid to really look at that and see if there's ways to help shift that balance a little bit more in terms of raising rates. So to Art's point, we have a financial crisis. We also have an entire healthcare system in crisis. So I'm going to walk you through the, each sort of aspect of our hospitals, but bear in mind that the whole healthcare system is impacting us right now, and we are seeing it in our hospitals. So in our emergency departments, we are seeing upwards of 30 people at a time needing mental health care, boarding in our emergency departments. So boarding means they're not really getting care, they're just waiting for their placement, and they're stabilized, but they're not in the optimal sort of level of care that they need to be.
Yeah.
Just a quick clarification, is this, I'm sort of wondering, are these numbers averages? Are they point in time? Are they system-wide? Are they in a specific hospital?
They are, they're system-wide, and it keeps going, it keeps changing. I think in December, we were seeing up to 30 people at a time per point in time. So we collect the amount every day, and that's what we've been seeing. I think the average is more along the lines of 24.
Okay.
Half of those folks are waiting for longer than 24 hours. And then beyond the folks needing mental health treatment or the patients needing mental health treatment, we also have people who are waiting for medical surgical beds, also boarding in emergency departments. So we've had 25 patients waiting for medical surgical beds, waiting in emergency departments. We have strived for parity in mental health and physical health, but this is not the parity that we wanted to see.
Can I just add to the picture? So those, in addition to those people that are boarding in the ED, there's a bunch of other people who are not waiting for a bed, but who are needing treatment. And
yes.
You may have seen news stories about how our emergency rooms are in crisis, and you're going to talk about workplace violence, but that the ED is one of those places because there's such long waits and so many people beyond the people who are boarding.
Yes. No, that's exactly right, Representative Cortez. So these are the people who are boarding. To help you try to paint a picture, you have people waiting for hours on end, sometimes days and weeks, incredibly frustrated. We've also seen, the whole social safety net is frayed right now. So we've seen families that don't have respite bringing in family members who don't need hospitalization. They just need a place to bring the family member to. But ultimately, the folks that we're seeing in the emergency departments should be there. What I'm hearing from our providers is that folks are coming in sicker, and this isn't a sort of situation where we could decant them to urgent care or send them to other places. They need to be there, but we are not able to find placements for them, and we've been having to send people with heart attacks as far as Connecticut.
Are these numbers pretty much spread across the hospitals in the state, or?
I think percentage-wise, I think percentage-wise, yes, obviously, yeah. Obviously, UVMMC has the bulk of the amount of people because they're our largest hospital, but a lot of our hospitals are at capacity, which brings us to our next piece, the sort of ICU medical surgical beds, the inpatient units. Last week, our beds were over 97% full. UVMMC and Dartmouth were reporting that they were at 100% capacity. And there were points where we had 3 to 6 ICU beds available in the state, maybe like a dozen inpatient beds available in the state.
So if there's an emergency that happens, there may be no place.
If there's a bad car accident that happens.
So I just want to be cognizant of the time because we do have a pretty hard stop at 9:30. So go ahead, and then I want to make sure she can finish.
There's such an issue that they're actually looking at putting ICU patients on a unit like mine, which is a progressive care step down from ICU. Like they're looking to find hallway space.
Yeah.
Really quick.
Really quick, comment?
Actually, I'm gonna go to Leslie because you already asked, so Leslie, really quick.
I don't know if you want to speak to this now, but I've heard that there were transformation dollars that were kind of promised to hospitals
As we went through Act 48 of 2000 and whatever. So I don't know if we can understand that now or sometime in the future, but I know it's affected hospitals and their work. And
Yeah.
that may affect our budgeting or our thinking about what we can do for hospitals.
Yes. I'm just,
So I just want to get your.
Let's hold that.
Yeah, I just want to get.
I think that's great. Unfortunately, those dollars have flown. We have no more access to those dollars, but I think it really makes sense in terms of our future negotiations with the federal government and the resources that we need.
I just want to get that on the table.
Yeah.
They were promised money that they never got, and that's crucial.
Yes.
It's part of the situation.
Yeah, and I think it just speaks to the fact of there's no, I think some people come in and say like, oh, just change it into a big primary care space and do this, and that takes resources. A lot of our hospitals are pretty old buildings, like all of that takes resources. It's not shutting off lights or anything like that. But I do want to hit this subacute care piece. So a lot of our capacity issues stem not only from people being sicker, but also the fact that our long-term care system and our subacute care system is really suffering right now, primarily due to workforce. And we have, we have beds available. There are beds there, but there are not enough people to staff nursing homes and other like acute, subacute care settings. Last week, we had 137 patients that were waiting for discharge throughout the state. And hospitals have seen 35% of their inpatient beds filled by patients who do not need to be in the hospital, but they have no place else to go. So that is really impacting our hospitals. Among that population are really difficult to place patients that need a lot of intensive hands-on staffing and care. So patients who have behavioral issues, they may be hitting people, they may be wandering, they need more than one person caring for them at a time. People who are receiving MAT treatments because they have substance use disorder. There are various regulations that impact our long-term care settings around that. So those are a lot of the folks that we're talking about. It's not, they are patients that do not need hospital level of care, but they do have serious issues and need someplace to go.
Is it adults and youth? Mostly adults?
Adults, older, yeah, older folks. So that brings us to our legislative agenda. And more of this information, you can see our whole legislative agenda if you click on this link. But what we're really trying to do is focus on access to make sure that our entire healthcare system is shored up so that it can care for Vermonters. And what we will need for that is resources to long-term care, resources to mental health. The public safety piece is mainly that workplace violence piece. So we've seen in our largest hospital, there have been recorded over 400 incidents in a year. So more than one a day, potentially. And any regulatory opportunities in terms of licensure and flexibilities that can really help ensure that we can get staff in, get them trained, get them ready to serve Vermonters in time, or sort of smooth the care that we're providing. Underlying all of this, again, is workforce. And again, that's throughout the system. So we do have travelers. I surveyed some hospitals. 5 hospitals got back to me, a mix of small hospitals and medium-sized hospitals, and they have 500 open positions. And my last piece would just be to say, what we have learned is that our system is so fragile right now. Anything that impacts the system, our hospital is likely to see it. It's likely to come home in our emergency departments. Please consider the entire system when you are looking at change, when you're looking at initiatives. Make sure you're not pulling staffing from one area to put it in another area, because that may break part of the system. So we really do ask, and we know that you have a wide lens, and we appreciate the work that you do there. So thank you.
And just to close before we move on, I think that last point is really important and something that we've started doing a better job of through the pandemic. I think as a healthcare coalition within the state, you've all started working closer together. I think we realize that we can't just look at one place, right? And so part of that is the discussion we're going to have from the BAA with the youth inpatient beds, right? So we're talking about youth inpatient beds, but that affects the flow everywhere else. And so we need to ensure, and we're going to have Boz back in tomorrow to hear testimony on the youth beds, but we just need to keep that in mind on everything we do now. And it's also why we're working much closer with the Human Services Committee. So thank you for this.
Yeah, thank you.
Devin is around and she's a great resource, and this won't be the last time we have her in the committee. So thank you, Devin.
Thank you.
Thank you.
All right, we're going to move to our friend Ina's back again. Hi. So we last year passed a pretty substantial workforce bill out of our body. It was signed by the governor. The bill was S11. Help me with the act number.
183.
183. Thank you. So and so we're going to get an update today on where the money stands. So what we probably should have done was done a walkthrough of S11, so you would see what we requested. But I think the way Ina will lay it out, we'll hit on the targets or the legislation that affected us, where we are with getting the money out. And I also we have two representatives from our commerce group, because although we did the work on the healthcare workforce, the Commerce Group Committee really did the whole workforce bill, and it was incredible work. So they've stayed close in contact with us. So if you'll just introduce yourselves.
I'm Kirk White.
Heather Chase. Great. So please feel free to raise your hand and answer questions. I want to make sure you're involved in this as well. So we'll go to workforce.
Thank you. And excuse me, for the record, Ina Backus, Director of Healthcare Reform Agency of Human Services. I'm going to use the same tactic of joining the meeting and sharing.
That would be great. Thank you.
Just resent you the link. I know I sent you the
It was just a little lag in connecting to the Wi-Fi. Hopefully it should be working now. That's it. You got it? I will try one more time, and then I think.
And then that's fine. And then we can all pull it up on our iPads if we need to. And for those watching on YouTube, it is posted under today's date, under the name of Ina Backus. Does everyone do you all have access over there, Kurt? Yeah.
It's connecting.
Okay, why don't we start, if you can, with what we have? And I think we all.
Okay. Great. Okay, muting now.
And
Oh, there we go. It just takes a minute to wake up.
Thank you for having me back today to talk about the workforce development initiatives that were included in Act 183 of 2022 and that focus specifically on healthcare workforce. As you referenced, that was a large bill, certainly focusing on workforce development in a whole, across sectors. But there are particular workforce development initiatives contained within it for, again, the healthcare sector. The first of those initiatives are emergency grants to support nurse, faculty, and staff. $2 million, and I should share that all of these initiatives have the funding source of federal, state fiscal recovery funds. And as we talk through the status of each of these initiatives today, the initiatives certainly are governed by the parameters and the requirements for how those funds can be used and can be spent here in the state of Vermont. Emergency grants to support nurse, faculty, and staff, $2 million were appropriated for this purpose with the intent of providing emergency interim grants to Vermont's nursing schools over 3 years to increase the compensation for faculty and staff, with the intent that that increased compensation could contribute to recruitment and retention of those staff that are so essential for ensuring that we can educate those Vermonters and educate those persons who want to work in Vermont as nursing professionals. This initiative, the Vermont Department of Health is responsible for this initiative. The Vermont Department of Health has indicated what those state fiscal recovery requirements are to the Vermont nursing schools and is working with the schools directly to assess whether they can meet the requirements of the state fiscal recovery funds. Once that assessment, which has been ongoing since the passage of this legislation, is complete, then there will be next steps that are identified relative to that assessment. And that's something that certainly the staff at the Department of Health, as well as others in our office, can follow up with you on.
Leslie?
so what happens to the funds if the Department of Health decides it's not appropriate?
First of all, the state fiscal recovery funds have these parameters for their use. And what's being explored right now is whether, as the recipient of those funds, the state nursing schools can work within those parameters. If it cannot work within those parameters, for example, I think there are some other potential approaches that could be taken with respect to the state fiscal recovery funds to see if they can be utilized, but utilized within a different or under a different structure. But the first step needs to be to see whether they can meet with the requirements, and then if they cannot, then to explore a waiver of those requirements. So that would be, I think, what we would expect the next steps to look like.
Is there a deadline for using the funds?
That is a really good question. I do believe that there is a deadline for using those funds. I will follow up with you on what that is. My colleague Wendy Trafton was going to join today, but she's sick.
Oh, I'm sorry to hear that.
She knows that deadline.
Okay, great. And I just made a note for committee members and for Commerce. We are having Vermont Department of Health come in hopefully next week, and I'll just ask them to also provide some updates on what they're doing.
Also with the funds, Act 183 asks that the Agency of Human Services offer $400,000 as nurse preceptor incentive grants. These grants are intended for nurses that are employed by critical access hospitals in Vermont for serving as preceptors for nursing students, again, to increase the capacity of the system to be able to educate and train more nurses in the pipeline. AHS, the Agency of Human Services, has defined this program parameters based on the Treasury guidance, based on what the state fiscal recovery funds would allow. And these parameters align with what's called a premium pay section of the final rules. So there's the way the state fiscal recovery funds kind of work are there's these different lanes, swim lanes, if you will, where they say if you're swimming in this lane, then you can appropriately use these funds. The lanes are pretty narrow. The premium pay lane is one that aligns with the state fiscal recovery fund program requirements. We've contracted with an independent entity to support this program administration. We do expect to be able to be accepting applications for these funds in the near future. There are some recommendations that come from the Nursing Preceptor Working Group, which I'll share with you as we work through these elements that suggest that this program could be expanded to have more impact. And there's, and so that is something that could be explored. So the Preceptor Working Group, this is not a funding initiative, but it was a requirement of Act 183 for the Director of Healthcare Reform or a designee to convene a working group of stakeholders to identify ways to increase clinical placement opportunities, establish sustainable models of compensating nurses as preceptors or hiring additional nurses to alleviate pressure on preceptors or both, and develop an action plan for expanding clinical placement opportunities. I'm going to swap now to the action plan.
Before you do that, maybe for new members, can you explain what a preceptor is?
You gonna phone a friend?
Or multiple friends.
It's one of, I've asked that question. I like to ask that question every time we're talking about the issue because I have heard it described in a number of different ways based on where people sit. And so I've heard it described as specific to those professionals who are working in a clinical setting to educate nurses or other healthcare professionals that are in training. I've heard that narrow definition, but then I've heard a more expansive definition too, where preceptors are also those healthcare professionals that are working in a clinical setting and are onboarding and training persons who are new to that setting, but already have their credentials and their training.
Oh, bingo.
So I'm just going to say in general, it is a healthcare professional that is working in a clinical setting who is either onboarding and helping another person come up or training a student. And what's happening now is, and correct me if I'm wrong, is basically they're doing that with very little, if any, additional pay, but it is an added workload to them. So this was found to be a key need when we worked through workforce issues last year. So great, thank you. If you want to move on to the document, that's great.
Okay. Hopefully this will be much more. I can toggle screens. I'm going to eventually get good at this.
Ina, can you send us this?
Yes.
Thank you.
Yes.
Yeah, I don't think we have this one.
And the designee that convened this group on behalf of the Director of Healthcare Reform is Laura Reshnig, and she works in the Agency of Human Services in the Office of Healthcare Reform. And Laura worked with this group to develop the action plan at my direction. This action plan reflects the requirements of Act 183, and those stakeholders who participated in these meetings were those that were prescribed by the legislation. Nursing schools, area health education centers, long-term care facilities, designated and specialized service agencies, federally qualified health centers, home health agencies, primary care practices, hospitals, and other healthcare facilities. We're all represented in these discussions. And as you'll see from the recommendations, there are 5. There's certainly more work to do in this arena. This is a very, significant and important part of ensuring that we have a strong pipeline for healthcare professionals in the state. And while the group convened and arrived at this action plan, there's more work to do. And you'll see that in the first recommendation, where the group recommends that there needs to be established an ongoing working group that can be composed both of nursing schools and clinical placement sites specifically, that could develop standardized clinical mandatories and clinical contracts across nursing schools and clinical placement sites, identify a responsible party that could host an online directory of clinical placement sites, explore how to send data on nurse preceptors to the Healthcare Workforce Data Center, which is also an initiative of Act 183 that is in process, and review the feasibility of rolling out a statewide clinical placement platform. And the first 3 recommendations are precursors to the 4th, and the group had really good discussion and shared interest in seeing if there were some steps that could be taken to experiment with and test a more central placement methodology before necessarily moving to and rolling out a statewide central clinical placement platform. So to do some learning through these first steps to bring together this information in a more consistent and centralized place. I think you could hear much more from participants in the working group who had, if you want to explore more deeply, who could talk about the way that clinical placement platforms function in other states, because they do great work in other states, but there is an investment in that platform and maintaining it.
So is the working group, I don't remember in the legislation, was there a time limit on the working group? Are they still meeting?
There was not a time. The working group had to produce the action plan for January 15th.
Okay.
The timeline for the working group itself was not indicated. The working group participants do think it makes sense to continue working in a more, perhaps in a more, even more focused way.
Great, thank you.
Yeah. The second action plan recommendation is around remote learning and simulation models. And this recommendation acknowledges that remote learning and simulation models can be a complement for in-person clinical training and can increase the clinical training opportunities and therefore make, create a more robust pipeline. Remote learning also allows nursing programs to expand their enrollment. The implementation of remote learning varies by setting across the state, and the working group recommends that the Office of Professional Regulation could develop a set of standards that could be applied for remote learning that would ensure that nursing students are receiving a comparable experience across these different settings in the state, and would encourage programs to pursue accreditation in simulation learning. So that could, again, broaden the opportunities for the clinical requirements for education. And
could you move that back up just so I see all of that? Right there.
It's broken into 2 pages, yes.
When I think of a preceptor in my brain thinking about healthcare, I think of a person working hands-on with someone in the hospital.
Mm-hmm.
I didn't think of it as a remote thing. Is this normal or standard for preceptors to I almost don't know how you do it. And I just want clarification on what role that has and what percentage maybe of preceptor training would be, or nurse training would be done this way.
Yeah, I think it's a great question. And this is not an area where I have deep expertise, but I think there are others who participated in this working group, for example, who you may want to speak with more depth on this issue. I do think that the simulation and remote aspects are increasing as components of clinical training, and that proportion, I think, the proportion of the remote or simulation relative to hands-on, I think is something that is really actively being explored.
So the preceptor would then go through their workday, helping to train a prospective nurse and showing them how to do their job, and then get on a computer somewhere and do some of that with other folks?
I think, again, I hesitate to say exactly what could be happening, but I think with these remote or simulation offerings, that they would be offered through a training program and might be offered by professionals who could be working in other states or professionals.
Okay, so it might not be that person.
Right.
Okay.
Yeah.
And I just made a note to invite the working group to our ever-growing list of things we're going to cover here. I made a note to invite the working group so we can spend some more time on this.
And the final portion of this recommendation around the simulation and simulation specifically is for there to be more work to ensure that nursing faculty do have training in simulation nursing. And so that the simulation training is, and others should correct me here if I'm wrong, which I may be, but it happens outside of the clinical setting, but it happens with a trained clinical educator. It's not like a self-directed simulation training, if that makes sense. The third area for recommendation are different models of clinical preceptorship that could improve access to and quality of clinical training in Vermont. And the working group recommends that there be a study of the current clinical precepting pilot sites that are currently being implemented or have been implemented previously in Vermont, and what mechanisms exist or could be developed to incentivize a more broad application or uptake of these pilots in Vermont healthcare settings. So I think there are a number of innovative pilots that are working in different settings across the state. And the work group was really trying to say with this recommendation, let's study what those innovative models are and determine whether it makes sense to, standardize or adopt more widely. The fourth recommendation relates to the $400,000 appropriation for the state fiscal recovery funds for the preceptors in the critical access hospitals, what we just talked about prior to talking about the action plan. And here the work group recommends that the program should have a new funding source that allows it to be distributed with more flexible conditions. The current funding source, the state fiscal recovery funding source premium pay channel or swim lane, is rather restrictive, and it doesn't fully align with the legislative intent, which I believe was to be able to support. I'm sorry. This one, I'm mixing up another one that we're going back to. My apologies. This piece here, I think it would be helpful to be distributed with more flexible conditions, particularly related to the public health emergency. Also, that the work group recommends expanding the list of applicable sites to include hospitals that are not critical access, as well as other non-hospital healthcare settings such as mental health and home health agency settings. Again, this was prescribed for critical access hospitals. And the working group recommends further consideration for how to support preceptors who are training newly hired nurses that are not student nurses. And finally, the work group noted that in recent years, a number of federal grants have been rolled out that could assist with the implementation of the recommendations that we just walked through, specifically, potentially a statewide platform or a study and evaluation of innovative precepting pilot models, for example. And so the work group recommends that Vermont nursing programs and clinical sites should develop a framework for submitting joint applications that could increase the likelihood of receiving funds in the future, and that could orient towards a statewide approach and standardization in that respect. Don't know what those opportunities are at this point, but the working group agreed that it could be very helpful to be prepared to have an aligned response to those opportunities to fund any of the things recommended here.
Thank you to the working group. It looks like really good work, so I look forward to having them come in.
Yes, and to Laura Reshnig too, who convened them.
Yes.
Thank you.
Thank you. My comments are directed in general, definitely not at you. I have to say I am frustrated knowing the context of the emergency that frontline workers are experiencing at the bedside. This looks like a fair amount of work, but I don't think it looks like none of it has reached the bedside yet in 9 months. And the emergency is, process is important, I understand.
Are you saying the money hasn't reached?
Or the effect of both the money and the effect of the working to make things better at the bedside, whether it's with preceptors or the pipeline. I'm concerned about how the pipeline that has not reached any nurse assistant that I'm aware of, or other individuals that are, for example, someone that I know who's a single mother working full time, trying to also do nursing school full time. Mm-hmm. So the people that we need to help are not getting help yet, and it's 9 months later. Mm-hmm. So I find that, again, I understand process is important, but I'm frustrated.
I think we all share your frustration. Yeah.
I think I'll go back to the various, all the recommendations in Act 183, because there are others that do, to your point, provide for funds that are intended to meet the urgent need. And you're correct that those funds have not yet been deployed. And we share your frustration. The state fiscal recovery funds are very restrictive in how they can be utilized and have required a lot of work in order to be able to make these opportunities possible.
And you keep saying state fiscal funds, but I want to be clear, the restrictions are coming from the federal government.
Yes.
It's money that's coming from the federal government and is flowing through to us. Unfortunately, and correct me if I'm wrong, Ina, what's happened a bit is since we passed Act 183 and we're anticipating it being, recovery money that would happen fast, rules have changed. And unfortunately, that's impeded our efforts to get money out the door. The other thing I want to take away from this is when we put emergency money in place, if we continue to get it, or if there's other money directed that we can use for these programs, we need to make sure that as a legislative body, we're not reinventing the wheel, right? So let's talk more about the programs, once these are set up, that are working, and how can we work in those parameters, achieve the goals we need to achieve to ensure money flows faster. I put that on us as a body to make sure we're looking at
Yeah.
that as well.
And it sounds like there's nothing else we can do as a state legislature to help this process along because the blocks are coming, restrictions are federal.
The next initiative is an example, I think, of where the state legislature can help.
Okay, so hold that thought. Art, did you have a question?
Well, I appreciate what you just said. And it seems to me, and maybe there is someone in state government here or in the healthcare piece of it that can explain when we authorize $400,000, they can walk us through the time it takes and what has to happen. And I wonder if there is someone who has that expertise, because unlike everybody else, $400,000, the next day there's somebody at the door saying, here's $20, here's,
Right.
That's what you think of when
Right.
you think of the expenditure of money, but obviously.
Well, I think, and I think we have to remember this was very unique, right? When have we ever received this much money in a pandemic? So we're all learning. And I think we're learning that when we think emergency funding might have a different timeline because of the process that
Well, and you see it in ARPA funds everywhere.
Right, exactly.
I mean,
It's not just.
Right, I mean, there's
So-
all kinds of strings to all this. And
Right. So it's frustrating, but I think good work has been done. I think we're getting there, and I want to hear, especially where we can take action to make things happen.
As we've been trying, and our staff have been trying and working, over time to make these monies available for these purposes, as well as the dollars included in Act 83, which was the budget adjustment last year, where we have provided for premium pay for retention and recruitment. And there have been more than 35 million of those dollars that have been distributed and more to come. So there are providers that are receiving dollars and have received dollars for those recruitment and retention initiatives, again, in Act 83. My colleague Wendy Trafton has done an update on that work for other committees, would be happy to do it for yours as well. And I think if today we are much better informed about how to recommend working, with these funding sources, because we have been doing so, but also because the Treasury guidance has started to solidify. It was also changing and being formulated, kind of simultaneous with our staff trying to get these programs up and running and the dollars out the door. So the recommendations here for next steps are informed now by that experience. The healthcare employer nursing pipeline and apprenticeship program, which I think you were referring to when you're thinking about those persons who are working nurses, advancing in their credentials, needing support. The legislative intent there was to wrap services, to wrap support around those individuals so that they could continue working and also pursuing movement along the healthcare career ladder, advancing credentials and so on and so forth. This program, $2.5 million was allocated for this program to provide grants to healthcare employers, including hospitals, long-term care facilities, designated and specialized service agencies, federally qualified health centers, and other healthcare providers to help establish or expand partnerships with Vermont nursing schools that could create nursing pipeline or apprenticeship programs or both, and allow for members of existing staff to be trained and further in their career development and become higher level nursing professionals. And again, the idea with we believe with the legislative intent here was so to provide support for these individuals where the defined program parameters and the Treasury guidance for SFR in this respect certainly is more restrictive, and we are exploring and have proposed options in the BAA to try to address where there's a mismatch with SFR and the program parameters as were defined in Act 183. But as it pertains to the program, we have contracted with an independent entity that can support the administration of this program. It is a grant program. It will require ongoing reporting and work with any of the successful grantees. And again, AHS has explored options available to meet the broader legislative intent, including putting a request forward in the budget adjustment. A healthcare workforce data center was also required by Act 183. We're in the process of recruiting for that healthcare workforce data center manager, as we are also in active recruitment for a healthcare workforce coordinator position. And consistent with all of the everything that was driving the Act 183 in terms of workforce development holistically for the state of Vermont, certainly not an exception that in the Agency of Human Services, the recruiting environment is more difficult now than it has been at other times. But we are working both to recruit both of these positions. And then finally, there was an initiative for designated and specialized service agencies workforce development, where the designated and specialized service agencies could use funds for loan repayment and tuition assistance to promote the recruitment and retention of high quality mental health and substance use disorder treatment professionals. Again, we've gone through the process of defining these program parameters based on the Treasury guidance, which is a process. And we can align, we see that there's an alignment with behavioral health care section of the final rule for the Treasury guidance for the SFR funds. We are working with the Department of Health and the Department of Mental Health on program design and implementation for this initiative. Go ahead, Leslie.
Thanks. I'm just curious, going back to the apprenticeship program, healthcare employer, the 2.5 million. And you're saying that AHS is exploring options, including going through the BAA. But the BAA is moving fast. So how do you think that's going to land, and what kind of process?
So the process will be that we were not tagged on that from the House Appropriations Committee, so Alyssa's actually doing some looking right now.
Perfect.
So we'll have Alyssa and Daisy check it out, and we will add it to our discussion when we do our committee discussion about recommendations for BAA.
So does that mean you'll have a recommendation in order for, so it has to come from them
So it
first?
sounds like it's in the BAA today.
Oh,
That's
okay.
Right.
Okay,
We just
so now
not-
it's in.
It must be it's probably under AHAC, or it's probably under Vermont Department of Health, which is under something else.
Yeah.
We'll dig and find it.
Okay.
And we'll bring it forth. So
Thank you.
We can follow up with you on that
if
too.
if you can flag it for us, that would be helpful. But we'll make sure we get it added. Definitely. So my question is on the two positions, I think it was. I see that one is a 3-year limited service, and the other one is also, that's for a full.
So his healthcare workforce data center position is not a limited service position. But the the funds are for a full-time FTE appropriation to establish and operate the workforce center, and the appropriation includes for the position.
I guess my question is, if we can't hire for those positions, can we repurpose that funding?
The healthcare workforce, I'm not the right person to answer.
That's fine. Okay, that's fine. No worries. Joe,
Well, then yeah.
Rather than a question, can I make a statement for discussion?
can we see if there's any other questions first? All right, Kurt or Heather, you both okay? Go ahead.
So I feel like, in the past week and a half, we've heard a lot, and particularly the VAHHS report that we heard a short time ago. I sort of feel like our village is on fire. And I feel like our village is on fire, and we hear from VAHHS, we hear what Mari said a few moments ago, we hear experience I've had or Topper spoken about in the committee, and it's on fire. And we have some group of experts that's saying, this is what happens when you build with wood. You really should have built with concrete. We want to move you over to a system of concrete building because this won't happen. That's great. And I see what they're saying, but our village is still on fire. And then I hear this report, because my initial reaction is, well, let's grab a hose, and it sounds like in the last legislative session, there are a lot of people grabbed hoses and they pointed them at the fire, but the water, the money, never flowed through those hoses and isn't hitting the fire and isn't helping to put out the fire. And so I don't know, I guess it's a statement more than a question, because I feel as a patient, I feel as a person, I feel as a representative, that, there's desperate need here for our patients, for our providers, for our hospital system, everything like that. And I'm just wondering, why isn't the water getting into the hoses? Why are we not, how do we, when my neighbor's house is on fire, I want to try to put out the fire. And I feel like that we're in a place where we are trying and things have been tried, but the fire's just not getting put out. I'm sort of wondering what more hoses do we need to grab, or where's the blockage in the system that is preventing the water from flowing to the hoses, the lines that have already been laid out for the fire. And that's, it's bothering me. I don't know an answer to the question. I don't know if it's really a question, but it's just over the past week and a half that we've been learning is a thing that I'm beginning to think about more and more.
So it's a very good analogy. And I think it depends on what we're talking about as to what the process is to move it along. I think in this circumstance, we're all very frustrated because we all worked extremely hard with the administration and with stakeholders to come up with a workforce. I'm going to call it the base of what we need to be doing to increase our healthcare workforce. And we need to start that. I mean, we should have been able to start it 6 months ago, right? And then use this session to build upon it. So, okay, what's working and what isn't? Where can we put more funds? And unfortunately, when working with the federal government, sometimes our hands are tied. I'm going to say personally, I also think we have had a pandemic, and it's not just the healthcare workforce that has been working overtime. It is our state employees who have to administer these programs and are trying to help with the pandemic, trying to figure out these swim lanes, trying to determine what our intent was and how it all works. And unfortunately, here we are. I think everyone is working towards the same goal. And we all understand the urgency. We all know that the village is on fire, and we are working as fast as we can in the parameters that we're in. That's the unfortunate situation. So our job is to take this information, get with the other various players, and continue the conversation and honestly pressure to say, we got to keep going. They understand the pressure, AHS system-wide, they know the pressure too, but that's our role. So it's frustrating. It's very frustrating. So welcome to being a legislator. So that's that's just my answer to it. Alyssa? And then we'll go to her.
I completely concur with absolutely everything that you said. And I remember us, desperately, where are we gonna point this hose? And we gotta do something to stop the bleed. Mixed metaphors, sorry. But to Art's point earlier, he had asked a question, and I sometimes feel, and maybe this is something that we can learn our lesson from in the future. Sometimes I feel like we're not hearing from the people in the administration that are the ones that are actually doing the implementation and the boots on the ground. So we don't know, you should not have to interpret our legislative intent. We should know, what is it going to take to get this money out the door? Where do we need to loosen up our language? Where do we need more flexibility? And we really should be hearing from the people who are going to be the ones that actually do the implementation of these. That's all
Yeah, that's right. That's true. And, I absolutely agree with you. And this was a whole new realm for us, with this federal funding. So.
Thank you. In the Act 183, there was also a number of grant forgiveness programs in the nursing program. Have you heard testimony on those yet?
We have not yet.
But because we saw VSAC 2 days ago, and they reported on those programs. There were several of them for some of your new folks. There's a Vermont Nursing Forgivable Loan Incentive Program, $100,000. Vermont Nursing Physician Assistant Loan Repayment Program for $2.5 million. A Nurse Faculty Forgivable Loan Program, $500,000. A Nurse Faculty Loan Repayment Program, which was $500,000, and then there was also a Vermont Mental Health Professional Forgivable Loan Incentive Program for $1.5. I don't have this information on all this, but I believe all but one, I think, of those programs has been set up by VSAC. They are getting the money out to applications.
Right.
In particular, the Vermont Nursing Workforce Incentive Loan, which was intended for nursing students to get up to full tuition to help offset educational costs with a 1-year work obligation for each year of funding. They currently have 146 folks that are taking advantage of that, 29 LPNs, 2 in an associate's degree, 102 bachelors, and 13 in graduate nursing programs. So they're spread out through our state colleges, 20 at Castle, 22 of those are in Norwich, 31 at UVM, 44 at VTC, and 29 of them are taking classes out of state, because the way it was set up was that we will pay for them to go out of state, but they have to come back and then work. So there is, it's not the water on the fire right now, but it is starting to put some resources in to eventually get more people holding hoses at least. So that's
that is wonderful. Thank you for sharing that. And I'm going to surmise that part of that success is because VSAC does that today, right? So VSAC, Vermont State. Oh yeah, I'm so bad with acronyms.
Student Assistance Corporation.
Assistance Corporation. Thank you. That's what they do, right? They put out loans. And so whether they probably had to set maybe something up, and we can have them come in and explain what they did, but that's their bread and butter. AHS and VDH, yes, they put out grants, but this was different.
Not their thing.
It's really different work for them. So thank you. We're going to end on that uptick of your good information. We're not going to end. We have more questions, but that's wonderful.
I'll just try to make a quick
editorial comment.
Quick thought. Yes. One, I love the comments and appreciation for the folks at AHS and elsewhere as part of the working group that put this information together. As someone who was at AHS during passage of 183, I really appreciate, Lori, your good perspective on the work that goes into the accumulation of voices that are behind this work and the expertise that it takes to come to a place where they can summarize all of it in such a succinct and direct recommendations. And Ina, I hope you're going to share the narrative of this with us that has those specific recommendations.
Yes.
But I also think that it's important to look at when we put something in statute that's like, and Alyssa, maybe this is what you were saying, is when we put something in statute that's like, you know, work with a group to send us recommendations. In order to schedule a group like that, you know, it's like, it takes so much time to get those voices at the table and to get everybody up to speed. And we know this from Vision 2030 and the Integration Council, to get everybody up to speed takes months. And so, I mean, how can we, and I look forward to learning from you all, how can we make those recommendations that are also timely? And Ina, I know you're familiar at AHS with the, you know, practice improvement office or something. I hope that AHS can strive to make operational or practice improvement efforts with how you operate your working groups, so that when you do pull together groups like this, you can expedite your own internal processes so that the rubber can hit the road a little faster on both of our ends. But I echo your frustration as well. Thank you.
Thank you, Daisy.
So I think next steps would be that we will bring the working group in. We can hear from BSAC, or at least get the information on their successful rollout so far. And we will continue to follow up with AHS on where the stands throughout the session to ensure things are moving.
UVM Medical Center also has a pipeline program that they've been working on outside of this work. It might be useful to have someone from there come talk about what worked for them.
Great, thank you for that. And we've been coordinating with Marianne Sheehan, who's been leading that pipeline work. If I think we're talking about the same one, to understand how that program works and how this program can align.
Great. Anything else, Ina?
No.
Wow, we finished early. Leslie? Well, we didn't finish yet.
No, mine's quick. I just went to the Commerce page and the VSAC presentation is on it.
Great.
So just search VSAC and it comes right up.
Great. Thank you. All right, everyone. I think we were gonna do, I had some block time for a committee discussion, but I think we'll just end and we'll be back here at 11.